I'm really very grateful to BAUS. Let's just see if we can get the slides up. Oh no, I can see them down there. Can we have the slides on the main screen, please? We do. I'm really very grateful to BAUS for allowing us to have this session, and I hope that you'll find it interesting. I'm very, very honoured by the panel that have joined me on the stage today. It includes a number of colleagues and friends who I've worked with in various different capacities over a number of years, and I'm really very proud and pleased to have them join us here today. You are going to hear from Alan Williams, who has really been an inspiration in this country in terms of setting transition going, realising the importance, and making a transition clinic work at where he works in Nottingham. Jo Begent is forever getting me out of trouble with adolescent patients at UCH. She's one of our wonderful adolescent physicians, and she's going to talk to us about the adolescent brain and how that is important in the process of transition. Claire Taylor works at Guy's, a testosterone-driven unit, where success is the founding word, and success is what she's going to talk to us about in terms of setting up a transition service and how you make that work. Andy Baird, for whom this is a home game, is going to talk to us about adult care and the importance of that throughout lifelong care with congenital anomalies. And I'm very pleased to welcome Sux Minhas, who works very closely with us at UCLH, and he's going to look at some of the andrological and fertility concerns in these patients and some of the data surrounding that. I'm very honoured that Hadley Wood has flown across the Atlantic to join us from Cleveland. She's really been an inspiration in the US in terms of setting up transition and congenitalism, as it is called in the US, but has done a huge amount of work with the AUA and various other learned societies in America in getting this work going. I was very privileged to work with Hadley in writing a book for which she did a huge amount of work. She's an industrious woman, and I'm very much looking forward to hearing her talk about surgical challenges as part of this session today. So in Europe, we've had enormous support from the ESPU and the EAU in setting up a congenital lifelong urology working group, understanding that there needed to really be a change in philosophy from really talking about in isolation pediatric urology, adolescent urology, and adult urology, and understanding the importance of the fact that these are lifelong conditions that need lifelong care, and they need people deliberately to take an interest in this particular specialist area of work. The pediatric problems, or the pediatric surgeons have identified the problem. They've looked after these patients superbly well and taken them through to their 16th, 17th, 18th birthday, and now the expectation is that they'll have a normal life, and they'll move on to have normal expectations as adults, and we need to provide the care for that. And that really needs to come from the adult urology environment, and it's become an increasing area of interest across the UK. I'm delighted to say there are a number of colleagues working with us, and that increases the discussion and the depth of knowledge that we can develop as part of that. But Christopher Woodhouse is really the founding father of that, recognised with D.I. Williams the importance of this and the need to get it started. So as part of a working group, we developed a number of objectives where we would have a multidisciplinary group. So we have nephrologists involved, we liaise with endocrinologists, with paediatricians, with urologists and with gynecologists, just as for instance. We'd like to, as we go on, build and attract a group of interested practitioners who want to undertake this work, either as the whole part of their work, like myself, or with a specialist interest as part of another practice, usually related to reconstruction. We'd like to form a network of people that will converse and talk about this type of work, because many of the patients are extremely complex, have very complex needs, and it's important to recognise that one person can't do it all. Over time, we may well see the development of guidelines and a standardisation in terms of the way that we approach these patients, and that's, again, an important part of the work that we're looking for. And over time, we also may see the development of fellowships or educational programs around this type of work and the progression for then further people to take the work on in the future. So we have a number of contributors to that working group. It's an important group. We meet twice a year at the ESPU and at the EAU to formulate a strategy and take it forward. And there are a number of ongoing projects at the moment. We've had an educational project with the young academic urologists in Europe. We had an educational session as part of the EAU in Munich. We are in the process of trying to develop a web presence, and we'll continue to have further presence and joint meetings, I hope, over the next few years. So I thought, just by way of introduction, I'm going to give you 3 case vignettes, all real patients, all from my clinic, just as a way of introducing the complexity of some of these patients and how they need a variety of different approaches. And then my colleagues are going to come to the podium and talk. If we have time at the end of the session, we'll invite some questions. So this illustrates the importance of the lifelong aspect of care. This is a 46-year-old man who emails me most Sunday evenings to tell me that he's having some UTI and a urological catastrophe of some form or another. But he was born with bladder exstrophy. I've never operated on him, but over the years he's had a number of operations and has a neobladder and mitrophanol. He has bilateral hydronephrosis, and gradually his GFR has deteriorated. He has chronic kidney disease with a GFR now of 35 when corrected for body surface area. He has recurrent urinary tract infections, and the challenges in managing that are that he doesn't void or empty dependently. He has to catheterize. He has a capacious urinary tract, and he has poor renal function in terms of the delivery of antibiotics to his urinary tract, so fighting any infection is difficult for him. He's tried a range of antibiotics. We've tried intravesical treatments and washouts to try and help with that, and we've involved our microbiologists in terms of trying to help him. But he remains a continued challenge, and we continually debate the next course of treatment for him. He's just one example of the type of patient that we would see on a regular basis. This lady comes to us and represents perhaps some of the psychological issues that we have, or the chronic pain management issues that we can confront in some of these patients. She was born with bilateral vesico-ureteric reflux and has recurrent left loin pain that doesn't really have a characteristic nature. It comes and it goes. And in 2013, I operated on her and I reimplanted her left ureter, because the only thing that we could find that duplicated her pain was a positive Whittaker test when we performed that. The MAG3 didn't show any frank obstruction, but again, because of the capacious nature of her urinary tract, it was difficult to interpret. She has 79% function on that left kidney, so it's worth fighting for and preserving, certainly, and she has no defined obstruction, but she's back with recurrent left loin pain. Her mother emails and phones my PA on a regular basis, almost daily, telling us that the pain is dreadful and sometimes when it goes away. And so we're left with a real challenge in terms of how we manage that, with no firm urological diagnosis or problem at the current time, a continued problem with pain, and therefore the need to involve other helpers in terms of looking after her. And so we've involved chronic pain team and psychology to try and help with delivering her the best possible care. Posterior urethral valves present us with a wide range of issues in terms of how we manage them in the long term, in terms of bladder and renal function, fertility, and so on and so forth throughout their life. This young man came to my clinic at 18. He was allegedly stable in terms of his GFR, which had last been measured about 6 years ago. But we noticed that his creatinine had just crept off the normal scale, so we rechecked his GFR, and it had fallen from 106 to 66 over the course of that 6-year interval, and this was our first meeting. We also discovered that he had a post-void residual of 600 mils, voiding around 900 mils or so before that. So a very capacious bladder, but not emptying completely. So he becomes a real challenge. He doesn't want to self-catheterize. He's a normally sensate, neurologically intact male. He doesn't want to use urethral catheterization. He didn't really like the prospect of having a mitrophanol for any other form of drainage. So he presented with us an enormous range of challenges. The one thing that all of these patients have in common is that none of them want to comply with the treatment that we try and persuade them to have. They all put up obstacles, some of them because of their confrontation and their involvement in medical health care throughout their lives and just the hexes that they have as a result of that. Some of them very real concerns and genuine reasons why they can't do that, and some of them representing perhaps some of the psychological or other issues that surround these patients. So it's with those vignettes in mind that I'd like to welcome to the podium our first speaker for this morning, and that's Alan Williams, who's going to talk to us a little bit about preparation for transition and how we might undertake that. Thank you very much, Alan.
Well, thanks very much indeed, Dan. It's great to be here. the session's been timed in a really prescient way, I think, because there's a fairly big institution not too far away from our hearts that is going to need to make some transition plans itself in the coming days and weeks and months. I got into adolescent and congenital lifelong urology because of two people. One is my mentor, Mike Bishop, who was really the polymath of urology, perhaps in the UK, but certainly in the East Midlands. And the second person who introduced it to me is going to remain nameless, because it was a pediatric surgeon that got up at an international meeting and said, you know, the really good thing about pediatric urology is when they get to the age of 18, they are someone else's problem. Some days you just can't get rid of a bomb. And it was those two things in mind, really, can't somebody else just do it, that started Mike Bishop off, and I got involved at the onset of our young person's urology clinic in Nottingham in 2003. And that's a clinic that I now share with Richard Parkinson from Nottingham as well. And just like Dan said, these are the sorts of patients who turn up at this clinic having graduated from the children's clinic. Difficult things to manage. These are people we could really do with a bit of guidance on. Because transition, its processes, along a whole breadth of specialty, was really pretty flaky. In 2014, NICE convened the Guideline Development Group, and in February of this year, we published the guidelines. Now, NG43 is not some obscure postal district of Nottingham. It is, in fact, the name of the guideline for transition from paediatric to adult healthcare. And what that is formulated is with a view to the legislation on how healthcare and social care from children's to adult runs, taking into account some of the more specific things that those of us who work in our little silos have to offer. Now, it's available in a few formats. One of the quite nice formats that I'd perhaps recommend you go and look at, if you haven't already looked at it for some other guidelines, is in the pathway, the online pathway that you can see on the website. If nothing else, this will make a pretty good handout for the rest of the 7.5 minutes of talk. Let's deal with a few specific issues then about planning transition. When do we want to plan transition? Well, transition is, of course, a process, not an event in time. The event in time is transfer. You could argue that planning for transition starts the minute you realize that you've got a congenital uropathy or whatever condition you're dealing with. So theoretically, for an antenatally diagnosed posterior urethral valves or an exstrophy, that could be at the anomaly scan at 20 weeks gestation. Of course, you've got to have a pragmatic way of doing this, and when developing the guidelines, we figured that the age of about 13 or 14 was a good time to do this. Mainly because it falls in line with legislation, for example, with looked after children in the UK. Now, 13 to 14 equates, just for the benefit of the non-UK people in the audience, with about year 9, 8th grade in America of the educational system. Another thing we identified was how important it is to have somebody named to try and take care of the whole plethora of things that need doing for transition. It doesn't need to be a doctor, doesn't need to be a nurse, just somebody who has the engagement of the youngster and whoever comes with them and looks after them, and also has access to the individual bits that that particular youngster is going to need, healthcare needs, educational needs, and so on. We talk a lot about developmental appropriateness, and in fact, developmentally appropriate is one of those buzz phrases that pitches up in the NICE guideline. We're well aware that you take a different approach when you deal with a neonate in the clinic or when you deal with a toddler or a surly teenager or with an adult. But equally, there's a degree of difference in where people are in their developmental stage that's not congruent with number of miles on the clock. Those of us who deal with children well recognize that people don't conform to standard developmental stages. The other thing, of course, is that by definition, development develops and changes. And it's important to try and review where we are and at what level we're pitching and planning things during transition. In pediatric practice, the patient is at the center of a family, and people go on about family-centered care. Now, of course, the gold standard for everything that we're meant to do as healthcare professionals is patient-centered care. And if you like, part of transition is to try and evolve from going from family-centered care up to individual patient-centered care. But we've also got to remember what the youngster wants to do about that, to what extent they want their parents, their carers, other people involved. We need to know what the parents think about it, because certainly for the first 16 years, they're the ones who have jurisdiction, really, over the child. It's not so much promoting independence. People, again, talk about this a lot, because as well we know there is a world of difference between somebody who has corrected penopubic epispadias, who's going to do fine, compared with somebody who's been multiply shunted, badly hydrocephalic, lots of revision surgery, thoracic level myelomeningocele. And with the best will in the world, the best we can do for those is the best to which they can aspire. Another European relic that's soon not going to be with us. Actually, this is talking about information, and we think it's important that people have information that they can carry with them. Be that a health passport or access to an online electronic record that can be accessed from multiple centres, or, as we've said in the guideline, a one-page summary. Not just to do with the healthcare needs, but also the way in which other factors interact with that. Now, having a summary of everything to do with the person as they go through transition and the named worker, I think prevents us, as I've alluded to before, falling into our little silos of treatment, and it just allows a little bit more integration and joined up thinking. Just winding up then, a disease-specific thing that's certainly played very large in my mind, particularly the more I've had to do with looking after the adults. It's changed the way that I manage my pediatric patients, specifically those people with spina bifida and neuropathic bladders. Now, the prospect, as we all, I think, in the audience recognize, of doing a horrible redo operation, or as I heard from one of my American colleagues, a horrible 3-do operation, when they've had a very straightforward, easy operation in childhood, because actually, don't tell my pediatric colleagues this, but pediatric surgery is pretty easy technically. The concept of trying to do less in childhood so that you either don't have quite so much to do later on in adulthood in terms of redo surgery, or whether or not we can actually get specific gains from doing less. And indeed, we've seen that we're doing fewer augmentation cystoplasties. We've seen that as a national trend. We've seen that as an international trend. And if the American pediatric urologists are doing fewer augmentation cystoplasties, there really must be something in it. This was a series from Sue Annabody and Phelan Murphy and Frank Lee's practice at St. George's, and they found what a lot of us have found individually, that we seem to be able not to do so much big surgery in childhood, but we're not struggling with upper tract deterioration. Now, a caveat here, I'm sure, and we've got data from registries, from the renal failure registries in the UK, but also in the US, that what we're probably doing is shifting the time of deterioration of the upper tracts from where we used to be in teenage years up to further on in adulthood. Now, that might have its own problems, but actually deferring it from childhood is no bad thing. So we've talked about some of the processes. How are we going to actually get this moving? Well, the Ready, Steady, Go scheme is a set of tools that we quite like. NHS England quite likes it as well. And it allows a set of documentation that the professionals can use, that the families and the individual youngsters can use, that assesses their readiness for transition up to the point at which we can transfer into the hello, into adult services. Ready, Steady, Go, hello. We've got to remember that services into which the pediatric patients have their transfer after or during their transition have got to be fit for purpose. There's got to be buy-in. Now, what we run in Nottingham is almost a cradle-to-grave service for congenital uropathies. The exact model that you have, I think, doesn't matter. The NICE guidelines, I do think, have a set of criteria built into them where commissioners and those who administer and manage the service can actually make provision for accepting what is a really complicated bunch of patients into the service, and the idea being that they just have a much smoother run. Thanks very much.
Working with us at UCLH. Joe.
Thank you, Dan, and thank you all very much for inviting me to be here today. I must make it very clear I'm a paediatrician, so my urological knowledge is small to non-existent. I think we're dealing with a fascinating and perennially challenging group of young people when we think of transition. And I think indeed, as Alan has kindly set me up for, the age we're thinking about is very variable. I mean, what is adolescence? It probably starts as you go into puberty and begin a hormonal storm, which my 10-year-old is definitely challenging me with already, and begins and ends somewhere after puberty is finished, which we know now it can be well into the third decade of life. And I think that Shakespeare would be reassured to know that even before his time, that had been a challenge for his predecessors. But it's certainly a challenging journey that is very, very different for every young person we come across and affected by all sorts of different ups and downs. We know that there are a huge number of young people in the UK, over 11 million, and that is more than there are over 65-year-olds. And this group come to A&E more than the over 65-year-olds and are now having more hospital admissions than children because we've done so well with infection. So this is a group of young people that are really presenting us with more challenges in healthcare than anyone else at the moment, and it's a really rapidly growing field. So as we're presented with challenges of how to look after them during transition, I hope that we can all find this a sort of interesting and challenging time. When it comes to urology, with my very simple view of your incredibly complex subject, in this age group, there are obviously the congenital group that you all deal with such exquisite surgery, a new and acquired group of problems that as they develop adult type issues, and certainly what I see in my practice in the adolescent field, some complex functional urinary disorders where we see young people with challenges of their psychological function, their autonomic function, and a great complexity of problems all coming together to give them real issues with how they pass urine and have other problems that really challenge us on a day-to-day basis. And of course, there are so many factors at play that we need to consider. And whilst you're considering the most sort of key aspect of that, we need to consider the aspects around it to try and help think about how to really look after these young people and try and make a difference, not only when we think about how they're to look after their key healthcare issue, but how that healthcare issue is going to affect their well-being and help them think about their development as they go forward into the world. And if we can get those other issues right, then perhaps we can help them have a better healthcare journey as they go into their adulthood. So why are adolescents unique? Well, we keep getting told about it these days and about the great challenges that they present us. And more we're understanding about their brains and the complexity that their brains present us. I would commend you to watch Sarah Jane Blakemore's TED Talk. She's a neuroscientist who works at UCL to actually properly explain this, but I'll have a go. Here you can see functional MRI pictures from the beginning of puberty at the top to the end of puberty down at the bottom. So that, for the sake of argument, is between roughly 12 and 24 years of age. So large changes. And we know that particularly the prefrontal cortex is the area of the brain that undergoes the most change during adolescence. This is the area of the brain where we control all of our impulses and deal with all of our planning sensible things. And of course, emotional regulation is controlled here as well. The other part of the brain that is most sensitive at this age is the limbic system, right in the very middle of the brain. And that's where we are interested in sort of impulse control. And what, of course, is interesting is little pulses of dopamine are emitted there, and we're very sensitive to those little pulses of dopamine. And in your adolescence, you enjoy those much more. And so anytime you get a thrill, anytime something exciting happens, adolescents are enjoying it even more than grown-ups. And that's every time your phone beeps, every time your mobile phone flashes a light or something sort of shines and seems tempting to you. Hence one of the problems I'll talk about a little bit more as we go on. So what is going on in adolescents' brains may well help us explain why they're a particularly challenging group of young people to look after, and some of the problems that Dan experiences in his clinic in helping this challenging group of young people make sensible decisions about their healthcare. There are some other issues that are, of course, important, probably, especially for teenagers, probably for all of us. And it's sleep, we know, changes during the adolescent period. It's an incredibly important time for anabolic growth and development while you're asleep. And of course, the body, as well as the brain developing, is physically developing hugely, and the majority of that happens while we're asleep. And we know that sleep has been eroded in our young people who naturally want to go to bed a bit later and get up a bit later. But school timetables continue to challenge that. The internet continues to get in the way of that more and more pervasively. And what we're expecting of young people socially and academically is really affecting how much they're sleeping. And there are clear studies demonstrating sleep dysfunction been more and more of a problem. Why is that an issue for us in healthcare? Well, it is probably affecting young people's health overall, and certainly affecting their mood and therefore their ability to make sensible decisions, which is all the more important when they're chronically ill. And our education system at the moment, whilst again, why is that important? Well, if we have happy children who are properly educated, hopefully we could help them make more sensible decisions. And our education system's great. It's not only important for their education, but for their psychological well-being, their social and emotional development. And it is quite one size fits all. So it's quite important to find out what's going on for our young people to help think about how we may be able to improve things there for them, particularly if they've got urological problems and perhaps need more quick access to loos, passes and things like that, which I'm sure you're all thinking about, but can be incredibly important for their self-esteem and well-being at school. The other thing we're increasingly conscious of, and this is work actually done initially in America, now been reproduced in Wales in this country, is about how adverse childhood experiences impact on young people's health and indeed on their brain development. Adverse childhood experiences refer to things like living in families where there's domestic violence or drug and alcohol misuse, divorce between parents. And having one adverse childhood experience is incredibly common. Up to 60% of children live in that kind of environment. However, once you get up to living in a situation where you're experiencing 4 of these, the chances of you, for example, being suicidal goes up 12 times. And we know that that has direct impacts now on your long-term health outcomes, things such as your cancer risk, your risk of hypertension and early death. So again, compliance with healthcare is really impacted by your adverse childhood experience and the environment in which you've been brought up in. Again, not things that are easy to influence, but if we know and understand about them and how they're affecting our young people, they may help make us understand their healthcare behaviours and tailor their healthcare more easily. We know young people aren't making very good healthcare decisions. There are some silver linings here. Alcohol and drug use in our young people is going down, and we all know the positive story about teenage pregnancies. But there's a very strong message that neglect in teenagers and young people, just at the time where they most need support from their families to help them transition into adulthood and make good decisions, is very predominant, actually, and probably more so than in young children, where it's an overriding message. And how about the internet? Well, this talk wouldn't exist without it. It's a fantastic tool and probably incredibly important to help us provide good transition services for young people who are far more tech savvy and indeed internet natives, unlike me, who's certainly an internet dinosaur. But our young people have grown up with the internet, and it's very much a sort of environment for them. But by the same token, it's also really deeply affecting how much they sleep, family structure, and indeed behavioural patterns in young people who spend too much time on the internet. Again, potentially affecting their behaviours with healthcare. We know that young people's mood and their behaviour and brain have been severely affected these days. And that, again, is thought to be multifactorial, related to low sleep, related to what they're seeing online. Body image is down, and many of your patients clearly will already have significantly affected body image. 9% of 9-year-olds feel they're fat, and we're having the lowest self-esteem recordings ever for our young people. 75% of mental health problems are diagnosed by the age of 25, and that will only be compacted by the fact we're seeing increased incidence of sexual offences and cruelty to children and young people. These rather alarming statistics are what is reported to the police, and it's thought that up to 1 in 4 girls and 1 in 6 boys are being sexually abused. Now, again, this doesn't necessarily mean this is happening to your patients, but if you're really struggling to engage them in healthcare, these are the kind of things worth thinking about, particularly as we know that young people with disability and with other significant healthcare problems are more at risk of abuse if they're vulnerable. So all these things come together to demonstrate, to show us that we're seeing really high levels of sad children. I would point out the suicidal issues box in the middle of that graph. These are phone calls to Childline, the helpline in the UK, that is a free, anonymous helpline that any child can ring. And they've had more phone calls about suicide than ever before. With all that doom and gloom, I wonder if there's something positive we can do about it, and I hope there is. I hope the transition guideline and the thinking about how we're all coming together as teams is something really positive that we're seeing, and the fact that you're all here today is a really great start. One of the things we're seeing with functional urological disorders is much more thinking in teams together about how what's going on for these young people, much more understanding about the workings of the autonomic nervous system. We know that their mental health is very compounding to these problems, but equally with our greater understanding of that, we can start to make more positive changes. And there have been millions of documents written about how we can help young people by the government, by the Royal College of Nursing and other agencies. But as Alan has already talked about, this new NICE guideline is really helpful and a big step in the right direction. A document that preceded that is the You're Welcome criteria from the Department of Health, which I would commend to you and is particularly helpful self-help sort of checklist for departments about are your facilities young people friendly, and whilst pretty exhaustive, and certainly as an adolescent unit I can tell you we're not doing a brilliant job. It just gives you a guide of things to think about, particularly when it comes to confidentiality for young people, which they always highlight as one of their key concerns, and steps to work towards building independence, as you've already heard about. And keeping the young person at the centre of everything we do is key to that. The notion of a key worker and a flexible service you've already heard about, but keeping things young person focused is obviously key, and involving them in as much of the work that we do as possible, and decision makings about how we develop our service again and again comes through as a key topic. You are all mainly working in specialist teams, but liaising with local services, so we get the benefits of their knowledge about the young person and the family remains a great thing to do. And joined up working with all the young people's team gives us great insight. We're blessed at UCLH with the services we have, and we go sort of seamlessly through from paediatrics into adult care, which we appreciate is a luxury. And we have an awful lot of mental health support, with psychology being the keystone of that, but psychiatry and psychotherapy also available to help us work with young people, occasionally unpicking fundamental mental health disorders, but more often helping us think with young people about how best to engage them in their healthcare. Again, we know that we're lucky to have that facility, but couldn't commend it highly enough to you to help engage young people in how to go forward with their healthcare. But also, I think staying engaged with their education is really key, and certainly in the oncology world, there's really robust data about young people who stay in education having much better healthcare outcomes. And physiotherapy and occupational therapy all been key to keeping young people on track with sleep and general well-being. So we try and work as a coordinated team. I'm afraid I put this slide in before we crashed out of the Euros. But more often than not, I'm afraid we're a bit more like this team, sitting around and chatting. And that's because we try and get a comprehensive psychosocial history out of all of our patients. And I appreciate that's more the job of us as paediatricians and the allied health professionals around a young person than you. But we feel that this information is really important to help us understand what is going on for a young person and why they're behaving the way they are. So this is the outline of an adolescent history, and allows us to build a team around a young person with them at the centre of it and their family also involved, to provide all the different aspects of care to support them through their transition journey and into being independent patients as they go into adult services. We have 3 pillars of healthcare with medical, psychological and therapeutic support, and we fit together to provide a biopsychosocial framework of care, which again aids that transition. Again, a luxury that we are afforded, but one that I think we should all be aspire to thinking about, if not having the services immediately available. And by liaising with schools, liaising with local teams, GPs, other resources that all patients have available to them, hopefully we can aspire to something like this. So in conclusion, I think all urological problems in teenagers, in fact any healthcare problem in teenagers, is compounded by the pressures of teenage life. A young person's environment is crucial to their well-being, and that goes both ways. So their illness will affect their teenage development will affect their illness. Smooth transition is a team sport, and as many members of your team that you can get together, the better. But no one size fits all, because we know that girls develop faster and boys develop slower. Sorry, but it's just a fact. And that we try and make it as individual as possible to get the best possible outcomes we can for each of our patients. If any of you are specifically interested in any of these issues, I would commend this e-learning health program to you. But I know there's quite a lot of other things for you to look at. So thank you very much for your time.
Joe, thank you very much indeed. Claire Taylor from Guy's is now going to talk to us about the route to success and setting up a service.
Thank you, Dan. Hello, everyone. So I work at Guy's Hospital. We have an adolescent service that was set up there. We call it Young Onset Urology, or the U service. And it's been going for about 5 years. It was actually a challenge and a pleasure to sit down and think about this talk, because obviously what I've tried to do is just distill some of the main features of an adolescent service that perhaps elevate it above what we're doing day to day in the adult world, the things that you need to perhaps pay a little bit of extra attention to when you're considering taking on one of these services. I've put it into kind of 3 or 4 main areas: basics, the staff, some of the services, MDT and data. But my disclaimer, which I'll put in early now, is these are just some broad brush thoughts. I'm not trying to be didactic. I'm sure everybody, as they set up services in their own individual areas, will have local pressures and ways that they'll need to adapt this to serve their own populations. Having said that, can I move on the slide? Can I have some help moving on the slide, please? Okay, well, maybe I just carry on talking for a moment. The first bit on the basics is, it sounds very, very obvious, but where is your referral base coming from? For us, it's the Evelina Hospital, the Children's Hospital. This is attached to Guy's and St Thomas's. And you need to obviously find out where these patients are coming from and establish a relationship with them. Really, ideally, you do need to have a strong connection to a children's hospital or a paediatric unit that's going to be feeding you these patients. Thank you. The local kind of GP population is really not going to be coordinated enough or looking after enough of these patients. And as all the people on this panel today will be telling you, this is a process. This is a process that's happening whilst these patients are going through the paediatric service. And you are just part of that process as they move over into the adult areas. And so it's not a simple referral letter in from a GP. The next thing, how are they going to be moved? And there are various different models that you could adopt. For example, are you, the adult team, going to go into the paediatric environment to meet and work with these patients before they come over to the adult side? I know that's the model that Dan uses, going over to Great Ormond Street to see patients in that environment. The flip side, which is actually what we tend to do at Guy's, is that we have designated clinics within the adult hospital, but we are joined by the paediatric urologist who supports our service. So the patients have still got familiar faces, but are being seen in the adult service. That said, if you are going to do that, you need to see them in a specialist clinic. Ideally, in a clinic on a day which is a little bit quieter. It's not really fair to take these 15, 16, 17-year-olds, as we've just heard from Joe, in the midst of their kind of teenage hormonal storms, and then just plonk them down in the middle of a kind of Lutz clinic with all the 60-year-olds. And something that I think has been very useful in our model is actually having the adult and the paediatric urologists there in the same clinic. It's great for just keeping the cross-fertilization of talk and ideas together, but also it means that there's a face from the old for these patients and the face from the new sitting there together and working together for them. So finally, on the basics, protocols and pathways. And I've put who, what, and why. When you're setting up your service, you've got to think, who do you want to see? Are you going to see every primary amniotic? People with dysfunctional voiding, who have all been in the paediatric service? Do you want to concentrate more on people with congenital abnormalities, multiple surgery patients? And so setting up your protocols and pathways, discussing it with the paediatric hospitals so that they know who are the right people to start funneling through into your service is, again, a useful thing to be thinking early doors so you don't suddenly end up with overwhelmed by patients perhaps you feel you can't help very well. So next, the staff. So this is our happy band at Guy's. Top left is Jonathan Olsborough. He's a transplant surgeon who does have both a paediatric and an adult practice. Complemented on top right by Arish Tagadaze. He's a paediatric urologist working at the Evelina Hospital. But actually, interestingly, in Arish's case, he actually started life as an adult urology trainee, and during his training got converted to do paediatric urology. But that's very useful because he does have some background in adult urology and understanding of that. And down the bottom, me. Again, I'm an adult urology trainee by training, but during my training, I spent a year at Great Ormond Street in the paediatric urology team, and actually time with Christopher Woodhouse and Dan Wood as well. So I have an insight and an understanding into how the paediatric urology world works. But probably most important of all is you need one of these. This is Winnie Nugent. She's our clinical nurse specialist. And she is the kingpin of the service. She works across both sites. She sees the children on the paediatric unit. She comes across to them in the adult unit. She is the person who's a point of contact for them, doesn't matter from which side of the service they're coming from. She's also the constant for them. And often, as we go on, particularly when you're talking about investigations or further treatments, she's the one who can be there with them, having had and established a relationship. She also, having kind of fielding all these inquiries from the patients, is very good at knowing where any of the rest of us are and tracking them down and getting answers out of us. So moving on to services. And again, divided these into two things, investigations and other specialist links that you need to think about. Now, this seems like a pretty standard set of investigations that you would do in a urology clinic. Why are they all up there? Well, they're all invasive, is the first thing to say. And you're talking about a group of patients that can have cognitive disabilities, they can have physical disabilities. They can just be people who have had awful experiences of invasive investigation, perhaps some of these like urodynamics in the past, and just are frightened or not willing to put themselves through this again after their previous experiences. So these all need to be handled with a little bit of care. For example, we have a designated video urodynamic session that I do along with Winnie Nugent, where we put these patients in there. They've got a friendly face, they're prepared beforehand, we take a little bit of extra time and care to try to make it a positive experience. Because if these are patients that are going to need lifelong follow-up and investigations, you want to try to make the experience a good one for them, to try to kind of counteract any negative experience they may have had when they were a child, confused, and quite a big thing to undergo. Perhaps by endoscopy, I should also put Botox, because as again has been mentioned, Botox is being increasingly used in these populations. Nuclear medicine, because of the GFRs we constantly do on these patients. You can't rely on an EGFR, particularly on patients such as spina bifida patients, etc. And finally, fluoroscopy. They all have quite a lot of fluoroscopic investigations. So a friendly radiologist who does these, who has a little bit more of an interest and an understanding, but also of the congenital abnormalities you may be showing. I mean, you're doing a fluoroscopic investigation, not expecting it to be normal. It was never normal on day one, and they have to obviously be able to appreciate that. And the other specialist links, this is not a comprehensive list by any way, but these are some of the ones that we have ended up nurturing and developing in our service. Renal services and transplant services already have transition arrangements. They're well ahead of us on this, partly because of the necessity. Children on dialysis need to remain adults on dialysis, and if you've had a transplant, you need to follow them up. They will have somebody who's responsible for transition. So it's just go find that person, go and have a word with them. They will be delighted to find a urologist who's got a special interest, because you'll become their go-to person. Excuse me. Reconstruction and revision surgery. If you can't do it yourself, then again you need to find a link to a unit where they can, because obviously these are patients who do end up having complex procedures and redo procedures. We're about to have a talk from SUCS about andrology and gynecology. You're getting patients as they've just gone through puberty. Suddenly, this is an area of their health which hitherto has probably not been addressed at all, but may become problematic. And leading on from that, and perhaps not for the 16 and 17-year-olds, but as they get older, they may want to have access to fertility services and also obstetric services. Both, I know again, Dan and myself now have established links with the obstetricians that look after the more complex pregnancies, and we are there at the caesarean sections of the patients that have had pelvic surgery in the past, just helping the obstetrician open the abdomen, knowing the abnormal anatomy that may be there, just to stop any unintentional injury of the urinary tract. And I have to say, there is nothing nicer than having taken someone through what often is a bit of a bumpy ride of a pregnancy, to actually see that moment where the baby arrives. And finally, very importantly, as Joe's just underlined, some form of psychiatric support for these patients, or knowing where to send them, whether it be in the community or within the hospital, to help them. So next, the MDT. It is really important in this service. And actually, I think probably it's more true to the basis of what MDT was thought to be. These are complex patients. There often isn't a right or wrong answer. We don't discuss everybody in our service, but anyone where we're considering a major intervention or we're not entirely sure what's the best way forward for them, for example, if they've got declining renal function or something like that. The purple names here are people who are routinely in our MDT. The ones in black, just to show you some of the other people who have come into our MDT to discuss specific cases. We do have very strong support from our paediatricians, and they come backwards and forwards for specific cases. The community support workers, they can be anything. We've had community physiotherapists, we've had people who may be the main carer for quite disabled patients of ours, who can come in and give that perspective. Also, finally, the cognitively impaired. We do bring in the community support workers who can often act as an advocate on the patient's behalf. For us, we have it once a month. It seems to work quite well. But again, that is something obviously you'll need to think about with the volume of patients as it goes along. And perhaps my final plea to you is do remember to record the data. It's interesting the ideas that are now coming out about the passports and single piece paper backgrounds on these patients, because they have complex medical histories. It may not be notes or history that you'll be able to have access to. They're a group of patients who are fluid once they hit the adolescent services. They'll start moving around in their lives as they work and grow up, etc. So you could kind of have data that follows around with them. They also, simple things, but get married, change names, things like that, and you'll need to keep tabs on them. So it is a thought about how you're going to do this, but do try to record the data. Keep tabs of your patients. Make sure that if they're moving out of your kind of sphere of influence, you are finding somewhere to pass them on to so that they don't go 6 years without a GFR check and then suddenly present with a problem. You kind of keep an eye on for them. So as I said, this wasn't meant to be comprehensive, perhaps a few ideas for people who are thinking of setting up a service. And good luck.
Claire, thank you very much. If I could ask Andy now, who we've worked in a number of different environments together, but Andy is obviously from Liverpool, so it's a home game for him. And I'd like to hear about the adult care of major congenital urological anomalies. Thank you, Andy.
Thank you, Dan. Hello, everybody. As Dan mentioned, this is home turf for me. I work just up the road in two hospitals, Alderhay Children's Hospital. In fact, we just have a brand new children's hospital in Liverpool, which we're very proud of, and Aintree University Hospital in the north of the city. And we've been providing an adolescent and transition role in the city now this is the 9th year, so it's really come quite a long way. So just a few thoughts from my perspective on where adolescent urology fits in and some thoughts about transition. These are my perspectives. I tend to see the adolescent urology being the application of all aspects of the care we give to all patients in general, but simply applying to young adults before, during and after the transition period to adult services. I don't tend to apply any specific age boundaries. As we've heard mentioned before, adolescent urology and transition planning begins quite early. My clinic is open really to young people when they reach high school, so around about 11 to 12 years old, and often onwards to beyond 16, 17, sometimes up to 19 years old. And really the thought processes we go to in our clinic locally are related to patient maturity, readiness for moving on, awareness, health education, those kind of things. We're very keen on fostering a culture of independent decision-making and thinking in all aspects of the patient-centred management. Many people talk about philosophies of transition. It's very much centred around preparing the young person and their family for the moving on period of their healthcare, the mind the gap concept. There are significant uncertainties to encounter and quite big changes to take into account when you're moving to a strange hospital with new people. We try and maintain some coordinated care across both medical and social aspects of care. And important to realise, as we've heard already, transition is a process and it's not a series of separate steps. And really the key to success is maintaining continuity. This is how our local transition pathway works. Referrals come from many sources, paediatric urologists, our consultant nurse team, and from a variety of other sources, my colleagues around the region, the neurosurgeons, etc., etc. We have a dedicated adolescent urology clinic on a weekly basis. There's a process there of assessing individual patient needs, implementing any changes and interventions that are needed, and then to review the requirements as time goes on. We have a transition meeting that takes place for detailed planning. We develop a person-centered health plan and then create a transition pack for transfer of information. This is often reviewed and agreed with the patient and their family before moving on to the relevant clinic at the adult hospital. Sometimes on the less complex cases, I cheat a little bit and make a step, avoiding all of this and going straight to the young person's clinic. For example, if I see a patient who's already 18, meet them for the first time, we can usually make the transition fairly swift and get them in the right place at the right time. And of course, there's a wide range of potential conditions that we come across, including neuropathic bladder, the spina bifida complex, other related abnormalities, tethered cord syndrome, the neuropathic bladder of unknown cause, common urogenital cloaca cases, disorders of sexual differentiation, etc., etc. Most of the interventions that we undertake as time goes on tend to be bladder-centred, but of course it's important to realise the bladder is not an isolated organ. And taking into account the complex neuroanatomy and physiology, the interplay between those is important to appreciate. So why do patients with congenital urological conditions need long-term follow-up? Again, not an exhaustive list, but these are some important areas. Upper urinary tract surveillance is of vital importance, and linked with that is detecting early decline in GFR. Maintaining the healthy bladder model, so regular catheterization, healthy fluids, prevention of infections, and troubleshooting problems early, I think, is one of the keys to success. And this can include difficult catheterization issues, difficult mitrophin access, problems with mucus and infections, and then take into account the whole team of people involved, the various health education issues, both physical health and sexual health. And of course, realising that there are huge potentials for a variety of problems to crop up: urinary infections, mucus and stones, incontinence, high pressure storage and reflux, pain and spasm, the tendency for pregnancy in complex individuals, as we've heard mentioned a few minutes ago, and the long-term risk of malignancy. So a few thoughts on tools of the trade. I think the concept of talking about the entire remit of adult care of congenital urological problems is a huge one, so I'm just going to really scratch the surface of how we approach patients. I think one of the really important aspects is the dialogue that you develop with young patients as they move through their journey. And for me, my personal approach is I think it's important to give people ample time, have plenty of time to listen to them. I try and have an open door approach. As Dan mentioned in his case overviews at the beginning, the complex patients, when they develop a relationship with you, they do have a tendency of trying to find you at inopportune moments. Regular emails, phone calls. I try not to get into the one-to-one contact through mobile phones and social media, but it's important to let patients have access to you when they need you, but with some ground rules to keep them at a comfortable distance, I think helps. And also trying to be as responsive as possible. Often patients need to contact you quickly They need some fairly swift intervention or help or advice, and they need to at least feel that they can come through the open door when they have a problem. And I think also equally important, as we've already heard, is developing the relationships between ourselves as the urologists and our colleagues in the hospital. I've deliberately put specialist nurses at the top of the list because I don't know what I would do without them. Having experienced this type of healthcare in other countries, that other people really struggle when they don't have access to good specialist nurse help. Very important to make friends with radiologists, have somebody in ultrasound, in nuclear medicine, in interventional radiology that you can call on when necessary, and similarly with nephrology, gynecology, psychology, colorectal team, and other people that I've not included there, pain specialists, neurosurgeons, endocrinologists, the list goes on. I think for me as well, one of the comforting things is having access to a range of different endoscopic instruments. The wider the range of endoscopes you have available at your disposal, the easier life is. And really with a list of different endoscopes at different caliber, with the help of decent guide wires, etc., you can get yourself really into and out of most spaces and trouble. So this is a range of instruments that I have available where I work. 9 to 11 French short rigid ureteroscopes. I have 14 French integral cystoscope, 17 and 19 sheathed scopes, standard 22 French scopes, flexible scopes, etc. You'll have seen these before. This instrument I find indispensable. It's locked away, nobody else gets access to it, that's mine. I also find the Nelaton catheters very, very useful, range of sizes, getting into Mitrofanov channels into the bladder to do washouts, which I find myself doing on a regular basis, and then access to the whole range of silicone catheter varieties. This is the kind of thing that I find myself doing fairly frequently. So as you can see, flexible instrument going into a Mitrofanov and lasering this fairly spiculated mobile bladder stone here. This is the type of battle-scarred abdomen that is often encountered. Old midline scar, umbilicus, Mitrofanov here, ace stoma here, several scars from, I think they're probably from VP shunt revision surgery. So it's not uncommon to be encountered with an abdomen like this, not knowing really what you're going to find on the inside. And with a Nelaton catheter in the Mitrofanov, washing out after the bladder stone laser procedure and getting nice clear urine back. So job done on that occasion. So conclusions, I would certainly say that our adolescent and young adult patients with lower urinary tract reconstruction in the past are a fascinating and complex but yet challenging group. They are our patients for life. It's very important to develop a good relationship with them. We do build long-lasting, trusting and rewarding relationships in the team. It's important to have a very high level of awareness for potential problems and to be able to help them rapidly when help is required. And the patients enjoy leading a very fulfilling, happy and healthy life with our assistance. And I'll leave you with this. This is, I think, the book that Dan alluded to before. This is an excellent overview of lifelong care for congenital urology, edited by Dan and Hadley, and I would recommend it to anybody who's interested. Thank you very much.
Andy, thank you. I'm very grateful for the plug. Sux is going to talk to us about the andrological concerns relating to fertility, sexual function and late effects. Thank you, Sux.
Thanks very much, Dan. Good morning, everybody. When I first saw this title, I sort of gawped a little bit and thought to myself, what am I going to talk about? If you look at the literature, there is, in fact, very little in the literature reporting on outcomes, especially in terms of fertility and in terms of sexual health in this group of patients. What I'm going to very quickly do, because I'm conscious, of course, we've got somebody who's come across the pond who needs to talk. I'm going to overview the late effects of cancers, because that's obviously very important as well. So many of these patients will have DSDs, will have gonadectomies, and will increasingly prone to having cancers, may have treatments for those, including chemotherapy. I'm going to talk about the congenital anomalies as well, and we're also going to talk about the effects of this. Clearly, the effects may be intrinsic or hereditary. There may be pathological manifestations of the actual conditions themselves, such as undescended testes, and of course the surgical interventions that are actually performed during adolescence or childhood, or the medical interventions, of course, can affect both as well, not only in terms of cosmesis, but also psychologically as well. So this is just a highlight in terms of oncologically, and it's interesting, if you look, you can't actually see this very well, but on this side here, if you look at testis cancer, for example, so some of these patients will have had cryptorchidism, had testis cancer, these type of procedures actually impair fertility, and it's important to remember this, because many of these patients will be coming to clinic wondering why they can't father children when they've come into adulthood. Most of this talk is going to be based upon the male patient, and again, just to highlight here, we've actually presented this data here, and what you can see here is kids with childhood malignancies, including both testicular cancers and lymphomas and leukemias, have quite significant impairment of their semen parameters to a marked degree, about 50% of them. Now, what's quite interesting is that even if you undergo treatment and you come back again and you relapse as well, you have a much higher risk of problems in terms of your fertility. The whole issue about obviously removing testicles as well in this age group, DSDs, etc. You can see obviously here's a patient with a tumour, you've got a TML as well, and the whole issue is about also the association of these conditions with fertility as well. So there is a pathological association from a number of studies, and these are just 3 such studies that I've highlighted. This is from Dan and Co. in terms of their ICUD publication, which is published in Urology journal, which I'd recommend reading because I read it. And you can see there are a number of conditions, of course, that are associated with a high risk of testis tumours. And we've got to realise that many of these patients, of course, will have long-lasting effects from these. Some of these effects, of course, are going to be due to chemotherapeutic agents that often are used in this group of patients as well. Some of them would have had surgery, some may have RPLND, and as such have bladder neck dysfunction as well, all of which could contribute to fertility issues as they get older. Furthermore, some of these drugs, of course, that are used in childhood for malignancy also affect DNA and affect the DNA fragmentation and the quality of the sperm and gametes as well. So again, looking at sperm count, if you look at older age group patients who've had cancer, and what you can see is the red bars. If you just look at the red bars for both FSH, inhibin B, and you also look in terms of the sperm counts, you can see that if you have radiotherapy, if you have surgery as a child, this all affects your fertility potential and your hormone function as one gets older. And this again highlights this, and quite interestingly, if you look here, just FSH goes up, which clearly can be a byproduct of surgery as a child. And if you look again at inhibin B and also sperm counts, it clearly affects your ability to have a child as they grow older, which of course is very important to people. So just a thought about that particular group of patients, you could look at this and say, well, can we do anything further? So those patients who are going to obviously have gonadal ablation in childhood, could you be biopsying these tests? And certainly people have tried to biopsy testes in the prepubertal patient, and whether or not we can use this in terms of cryopreservation and spermatogonial stem cell transplantation in adulthood, of course, remains to be seen. But what's quite interesting is a study here on the left-hand side, which basically looked at this, and it's quite amazing that about 80% of patients find it acceptable, or parents find it acceptable for their son or to have this type of surgery, in other words, a biopsy to try and preserve spermatogonial cells. So it's something that maybe we should start thinking about as well. If you focus basically on the congenital disorders, of course, and I've just focused very quickly on cancers, and there's a lot more data out there on that, you can see here that there are a number of cases. The list is exhaustive in terms of potential congenital disorders of the genitalia, but we're going to focus mainly on the epispadias group of patients and also hyperspadias as well. So clearly, some of the problems what kind of problems do you get in adulthood? Well, clearly there are psychological issues, and we see many patients that Dan will refer have psychological problems, both which may relate to physical problems as well, and clearly also cosmesis, all of which really ties in and all of which is interrelated to each other. Some of these patients will have residual scarring, some of them will have dysmorphophobia, some of them will have micropenis as well by definition, residual curvatures, secondary to chordae as well, and furthermore may have fistulae as well and scarred penises as well, and they may perceive these as abnormal. In terms of erectile dysfunction, clearly, because of the cosmetic effects or that they have in terms of their body image, they may, of course, have psychological issues about this as well. And clearly, there is also hypogonadism as well in terms of the surgeries they've had and in terms of potentially fertility problems as well, which could either be due to impaired spermatogenesis, the actual defect in itself in terms of such, for example, with DSD, and all of which can contribute to fertility issues in this group of patients. And you can see here, it's just a picture here, courtesy of Chris Woodhouse, in terms of a patient who has clearly got functional problems there. Well, how does it affect these patients? If you look at the data, there is very, very scant data within the literature in terms of the psychological sequelae of surgery as a child. And interestingly, if you look at male patients, about 10 to 20% do not show any established relationship with women, which is quite interesting. There are feelings of insecurity and worry about their sexual relationships. Adult men operated on, for example, hyperspadia surgery more frequently recall depression and anxiety, compared to their peers. And certainly hyperspadia patients are less likely, interesting, to live with their partner. I'm just going to examine a few of these issues here. Again, this is a publication from Dan and Christopher Woodhouse, looking at penile abnormalities in adolescents. And if you see down here, regular sexual intercourse and psychological problems occur in about 60 and 38% of patients. Quite a significant number, therefore, have problems as they go into adulthood, which isn't surprising, of course, as when you then have this type of appearance. Many times they'll be obviously scared of undressing in front of people, and of course it's very difficult for them to have relationships. Penile size, of course, is important, particularly in hyperspadias, and it's interesting, almost 50% of patients complain that their penis has been ridiculed by their partners. You could, of course, divorce them, but the point is that they've got to live with these people. Proximal hyperspadias as well, it seems to have much more severe problems in terms of penile size, which isn't surprising in many ways. And also patients are often more ridiculed and also have a sense of problems in terms of cosmesis as well. If you look in terms of dissatisfaction in terms of penile appearance post-surgery as well, there's high rates of dissatisfaction, and many of these studies have shown this, with glandular shape, scars, as well as penile size being obviously important aspects in terms of complaints. And it's interesting, this is a good study looking at long-term and functional outcomes in terms of hyperspadia surgery. And what's quite interesting, again, you can't see this from the back, but a significant number of patients have erectile dysfunction, about 20% of patients. And furthermore, it's interesting, dissatisfaction with the appearance of the penis itself, 36%. And these are quite stark and startling figures, really, for those of you who are doing this surgery. And you suddenly realise long-term, and it's interesting what Alan said about at the age of 18, somebody else takes them over. Well, it's interesting, somebody else does. And it's quite interesting, isn't it, the problems that these patients have and the degree to which they have them. This is, if you look at the red, and you look at the blue bars, that's the important thing on this one. And again, this highlights in terms of erectile dysfunction that occurs significantly, dissatisfaction with appearances. And this is a very good study, and I recommend that you read this in terms of the psychosexual effects, also physical effects of hyperspadiac surgery in childhood. And up to 50% of patients are dissatisfied with the appearance, which is clearly significant. And this is quite a good study because this is a controlled study. If you look at the extrophy patients, these, of course, are much more severe in terms of abnormalities, in terms of penile size and scarring. Often they have quite marked curvatures as well. And you can see the figures there, of course, quite in a very small, limited number of series of patients, and actually quite historical in many ways. But if you look at these papers, you can see that up to about 45% of patients have penile curvatures, still have problems as they go through a transition period. For me, a transition period, of course, is in the older age group. Psychological problems, again, if you look at these, and it was highlighted earlier, if you actually have a look in terms of the patient, in terms of the satisfaction, in terms of the appearance, in terms of when they undress, in front of people, in terms of masturbation compared to having sex, more of them will masturbate, but actually fewer of them will have sex. So clearly there's a major issue here in terms of their body image and what they perceive as normal as well. And likewise, this study highlights here exactly what I just said about erectile dysfunction and ejaculation, pretty high in the male group as well as the female group as well. But if you compare it in terms of masturbation, of course, they're more likely to masturbate, of course, because they're not going to be with another partner. So how about fertility? How does it affect your fertility? Well, it's interesting. Again, this study in terms of hyperspadias patients who were operated on for hyperspadias showed, in fact, there was quite severe abnormalities in semen parameters compared to a control group. This was, and the second group here, HAGD, are those who have gonadal problems as well in terms of cryptorchidism or have had carcinoma in situ. And these, of course, not surprisingly, because they will undergo further treatment, will have much more severe abnormalities in their semen parameters. So not only do they have physical and psychological problems, of course, in this group of patients, that of course affects their fertility as well, and therefore they're less likely to reach parenthood. And this has been shown in some basic studies. So if you look at these studies, and this is a very good one again, you can see that patients who do have hyperspadias on its own, or those that are associated with other congenital problems such as cryptorchidism, have a much higher rates of abnormalities both in count, motility, as well as abnormal forms as well, which is clearly of significance, as obviously having children in this group of patients is important, as it is to everybody. Again, if you look at hormone function as well, this highlights FSH and LH in this group of patients is also interestingly higher compared to a control population as well. And if you look at free testosterone levels as well. So clearly there is also an impact in terms of not only clinical but also biochemical hypogonadism in this group of patients as well. In the EEC patients, of course, the problem is there's very little data. And in fact, if you look again at the data in terms of sperm production, one of these probably spermatogenesis is impaired, accounting for azoospermia. But look, if you look at the figures, almost 50% of patients are azoospermic who have EEC. So very high figures. And in fact, many of them may also have abnormalities in other semen parameters as well. Likewise, in the female patients, in terms of live birth rates, is only 56%, which is a lot lower than actually the general population or control population. So it is quite significant effects of these problems. So what's the potential role of the andrologist? Why am I stood here? Well, the answer is, of course, we have clinics. We run clinics side by side, which is very good. And often Dan will refer his patients in, including those patients with Klinefelters. Psychological support is provided. We can also provide treatment, of course, for erectile dysfunction, pharmacotherapies, including prosthetic surgery as they get older, because in some of these patients that is the only option in this group of patients. We can, of course, treat their hypogonadism, of course, taking into account the effects of testosterone replacement therapy on fertility function anyway, but certainly in terms of growth, etc. Assessment and treatment of subfertility as well. We can, of course, retrieve sperm from these patients' testicles as well, which they can subsequently use for assisted reproductive technologies as well. And whilst, of course, we can do reconstructive surgery, including penile curvature correction, treatment of lymphedema, and also cosmetic surgery, including phalloplasty, we also got to remember that these patients clearly have a stigma attached in terms of the fact they've had major abdominal and genital surgery as children. So I'm going to summarise very quickly and say that there is very little data, and in fact most of the data I presented is probably the data within the literature reporting on long-term effects of congenital anomalies in fertility and sexual function in this cohort of patients. A significant portion of men, as you've seen, with congenital urogenital anomalies have long-term psychological and physical effects on their sexual function and fertility. And I think the andrologist does need to work closely with the transition group and team to ensure that the psychological and physical needs of this difficult group of patients are met, because of course this will have lifetime effects and improvement in their quality of life. Thank you.
Sux, thank you very much indeed. It gives me great pleasure to welcome to the podium Hadley Wood from Cleveland, who's going to talk to us about surgical challenges in adolescent urology. Thank you, Hadley.
Thanks, Dan, and to Mr. Speakman and the committee for inviting me here. It's really an honor and pleasure to be here. My background is in adult reconstructive urology, and so just to sort of, because I know the systems are a little bit different, I actually pick patients up in periadolescence and young adulthood and go through them throughout their entire lives. But I'm going to just focus this talk really on surgical issues pertaining to periadolescence. So we'll talk first about some preoperative considerations, and then some sexual conditions, and just a touch on the fertility aspect, and then cosmetic issues that arise in this population, and finally just sort of talk about the way I think about bladder, incontinence, and reservoir issues, along with fecal incontinence issues. As Joe mentioned earlier and described so well, these young individuals are so challenging on so many fronts that even if they didn't come to us with very complex medical problems, they would be a challenge with the psycho-emotional aspects of their care. And in particular, for young individuals who are just coming into their sexual years and having questions and issues related to sexual function. When I think about the surgical problems that I see in adolescence, I sort of group them like this. Sexual conditions, and most of those are male, in part because I am trained in male genital reconstruction, and in part because this is the primary area of focus for most young men. Also, some cosmesis issues, and that I see quite a few young ladies who are dissatisfied with the cosmesis of their abdomens after multiple operations. And finally, bladder problems, which are either primary for patients who have not yet become continent in childhood, and those are the majority of those patients are myelo patients or spina bifida patients, and that's a very challenging group. Or patients that have secondary incontinence related to malfunction of their continence mechanisms, stones, or other problems. So it's important to note that most young people coming to see me they're not coming to see me with a life and death situation. They're coming to see me with a complaint of a functional need. And in many situations, like this phallus here, the risk to operate on that penis may be considerable in terms of potential for loss of erectile function or sensation. And these patients' experience may be very limited. I get some patients referred from the Middle East with several uncles in the room and a father and maybe an older brother who are coming specifically to find out what I can do to help make this young man marriageable. And in 2 instances, those patients have been diagnosed with CAH. So these can be really tricky conversations in patients who have never had any sexual activity, and in some instances may not even at least admit to me that they've masturbated before. So it's really important to understand what their goals are and to set some pretty clear expectations. Obtaining prior records is really ideal. It's unachievable in many situations, particularly I think law in our country only requires that these records are kept for 7 or 10 years, and so oftentimes I don't have a good understanding of what has been done in the past, and so oftentimes I use fluoroscopy or sometimes imaging, cross-sectional imaging, to understand what the patients have had done, and what they may need to have done. When thinking about these patients perioperatively, some of them have very specific perioperative needs that can be challenging. In particular, for developmentally delayed adults, I have a patient that I'm operating on in 2 weeks who is minimally verbal, Down syndrome patient who requires having his parents with him to help translate what he's saying. And in our hospital, almost all of our beds are shared rooms, which makes that very difficult. So I have to make special accommodations for adult patients that need sort of pediatric accommodations. And in other aspects, young men that come to me that are 17 or 18 that are getting phalloplasty for congenital cord D, I often send to my adult urology ward if they're going to stay overnight, and that's specifically because they're having, as I tell them, you're having a grown-up surgery, you should be on the grown-up floor. And some patients have pretty profound anesthetic issues, and that's, in my practice, is mostly patients with coagular anomalies and congenital heart diseases. We have a large group of patients with adult congenital heart disease at my organization, and I do get a lot of those patients referred for even routine urologic care. In fact, last week I operated on an 80-year-old with tetralogy of Fallot. And he actually just had a fairly minor operation, but I had to admit him to the adult congenital pediatric service for his heparinization and bridge, and we actually operated on him in the pediatric operating rooms with a pediatric cardiac anesthesiologist, because of course that was the greatest risk of his operation. So this is sort of how I group the sexual conditions that I see. Erectile function, I actually don't see that much of in adolescents. I see it in a lot of these conditions as they age into adulthood. But really the only patients that I see with a big complaint of erectile dysfunction are the spina bifida patients, and then a minority of extrophy spectrum patients. CORD is seen sort of in three varieties. Patients with congenital CORD who go about their lives and then discover when they have their first sexual encounter or watch something on the internet that their penis is not like everybody else's. And so they usually show up around the time of high school or college requesting revision. And then patients with hypospadias and epispadias, as Suk had shown some photos of that. Patients with insufficient phallic length, that is a very common complaint, and again, oftentimes in patients with hypospadias and DSD spectrum, as well as some of the extrophy patients. And then some ejaculatory issues, particularly in patients who've had urethral reconstructions with epispadias and hypospadias, as well as patients with posterior urethral valves can have profound ejaculatory problems. And then finally, among the women, dyspareunia is really the number one thing that I see young ladies for from a sexuality standpoint. And those are mostly extrophy spectrum patients and patients with vaginal anomalies. So I always start by really asking them what their experience has been and what their goals are. And again, this is really challenging. A lot of times they've never even been to a doctor without their parent in the room. So, and many of them haven't ever had a conversation like this before. So as Joe mentioned, this is pretty tricky grounds. And really, I really try and get at how pressing the problem is to the patient's overall well-being, because we will never, it's not technically feasible to make an extrophy penis look like the penis that these young men have seen on the internet. And so it's really important to understand how much their concerns about genital appearance are really impacting their ability to be a functional adult. I saw a young man last Friday he was 22, and he'd absolutely never even asked anyone out on a date because he was so concerned what that may lead to, and that somebody would actually look at his phallus and have an expectation for him to have something more than what he has. And that patient, I think it's pretty critical to have a very honest conversation about what is possible and what is not possible. I also, while many adolescents are not even thinking about fertility in that moment or in that period of their lives, many of them have thought about whether it's possible for them to be fertile. And importantly, many of them assume that they are not fertile. So I have a very, very direct conversation with them about what we know about fertility with their diagnosis. And every single young man who may have problems with fertility, I offer a baseline semen analysis to. And the young ladies, I refer over to our high-risk OBs just for a discussion about what pregnancy may entail, and for those who are have spinal dysraphism, to start them on high-dose folic acid as soon as they become sexually active. I'm not really going to talk too much about erectile surgery for erectile dysfunction. Most of the patients with spina bifida problems can be managed medically, and so I sort of just go up the chain like we all do. I just would like to make a nod to the Tomax procedure, which we're starting to get ready to do, and there's one organization that I'm aware of in the United States that's doing that, which may increase erectile function for, may have some options for young men with myelomeningocele. And then, of course, penile implant, which we all know about. For Cordy, this is the young man that you saw before. He underwent bilateral corporal reconstruction because he had profound dorsal curvature that impaired his ability to have intercourse. He had had some experiences before, so he was well aware of what his limitations were. And you can see he still had some phallic insufficiency, and so after his surgery and after his recovery, we put him in a traction device, and he has actually gotten a little bit more length and is much more satisfied with his function. Congenital CORD is a much easier problem to fix because the phallic insufficiency is not present typically, and most of these patients have downward curvature. It's my preference with these patients to do a true excisional Nesbitt type of plication here. As you can see, with excision, I mobilize the superficial dorsal vein and then excise an ellipse, and then if they have any lateral curvature, I typically do an incisional modified Nesbitt type of procedure to straighten that. I have not seen, I've only seen one patient with really, really bad lateral curvature. Typically their lateral curvature is much less significant than their downward curvature. This is the problem that is the hardest to fix, and I think David Ralph gave a talk on this yesterday, which I regrettably missed, but he certainly knows more about this than just about anybody else in the world. So I do sort of utilize these traction devices for patients that can get into one. The problem is that they need at least about 4.5 or 5 centimeters of stretch length to be able to get into one of these devices. But while you can hardly motivate a teenager to do anything, you can definitely, getting a young man who's concerned about his length into a traction device and using it actually is not very challenging. They're pretty motivated to use it. This young man here was one of those patients that I told you about, was referred to me to optimize for marriage. And you can see that there really is no opportunity to optimize that. That patient will never, no matter what you do, have a phallic length that is functional. And so in that situation right now, the only option that's really available on a widespread basis is a free flap add-on type of phalloplasty. And that's what this patient subsequently had, as I suspect Mr. Ralph talked about yesterday, that getting secondary implantation of a device into those and not having them erode is really the challenge that we're struggling with right now. They are a little bit easier to get in and have functional outcomes than the patients that have neophallus for transgender surgery, because they at least have corpora into which you can seat the device. There's all sorts of ejaculatory issues. I just want to mention this one, which I call recurrent epispadias. And I've seen several young men, about 6 or 7 young men who've had exstrophy. Most commonly have had pouches, and either the bladder remnant has been left in situ, or the bladder has been removed, but the posterior urethra and prostate are left in situ. And this young man actually had fairly decent erectile function, but every about 2 weeks would become septic and get admitted with increasingly multi-drug resistant purulent drainage from this little area right here. And you can see the fistulogram shows nicely his posterior urethra. And this is actually not his bladder, it's a seminal vesicle. And he subsequently underwent completion prostatectomy with excision of all that. And despite laying awake for many nights in a row, concerned that he would never have an erection again, he still has erections. This is an extrovert patient who had sort of old-style Cantwell-Ransley repair, and he was admitted with a PICC line in after multiple rounds of multi-drug resistant infections with this retrograde urethrogram. And you can see this large diverticulum, which I removed. I also performed a vasectomy, which got him out of the woods with respect to the infections. But he actually was not interested in treating his incontinence and went back to West Virginia in a diaper. For the females, I just want to point out these 2 images. This is sort of a standard cross-sectional image of a woman unaffected with exstrophy, and here's an exstrophy patient. You see the vagina is foreshortened, and the direction of the cervix is more directly in a straight line instead of sort of protected back. And so I see some of these patients have some difficulties with pain from intercourse, and that's a really tough problem to fix because you can't really make the vagina longer and you can't really change the direction of the the cervix, and convincing them to find a partner with a shorter phallus is challenging too. So, oftentimes these patients have a little introital stenosis, which can be fixed with a little vaginoplasty. I had a 15-year-old woman come in with that complaint, and I did her vaginoplasty, and then exactly 10 months later, she delivered a baby. So that's one thing that I always mention. While many of the men are subfertile in my practice, women with exstrophy are suprafertile, and so they have to be very, very carefully counseled about their fertility risks, and as well as counseled to use barrier contraception. Cosmesis, I've seen a couple patients with cosmesis questions that want touch-ups of their introitus after extraocular epispadias repair, and of course prolapse, which can go along with the dyspareunia or cathing issues. I'm not going to say really anything about fertility, except that I offer semen analyses to all of my young men who are thinking about this, so that we have some baseline, and I refer the young ladies over to a specialist gynecologist. The genital concerns sort of run the gamut. Cosmetic concerns. This is a young man born with a hypospadias that was never fixed, and he just wanted it fixed. And so, it's rare to see these patients show up in adult life with that, and sometimes that's a little bit of a concern, because oftentimes they may have other psychosocial issues that go along with it. So those are pretty straightforward fixes. The abdominal wall cosmesis we see mostly in young individuals like this with exstrophy or spina bifida or colorectal anomalies, and in particular patients with Eagle-Barrett syndrome who want abdominoplasty. And so I'm just going to talk briefly about incontinence management. And these are really two different flavors. There's the patient that has persistent incontinence from childhood, who's never been continent. And those patients are very, very difficult to really get to have a successful outcome, and also to understand how much work it's going to take for them to be continent. They often tend to be patients that have a track record of noncompliance or come from a very chaotic home, and so those patients require quite a bit of psychological and emotional support. And then the patients with secondary incontinence sort of are just like all of the adult patients we treat in terms of working the pathway of why they are all of a sudden incontinent. And I'll just go through two cases to illustrate that. This first patient is a 16-year-old young lady who had an augmentation cystoplasty and appendicovesicostomy as a young girl. She's had a bunch of urologic surgeries, bladder stones, slings, a bunch of injections, and she's also had quite a few non-urologic surgeries, including several shunt repairs and some back dethetherings and Nissen fundoplication. So she's essentially had a major surgery every year of her life since she was born. And she's pretty much fed up with all of her providers and with all of her doctors. And she was cathing every 4 hours, or claimed to be, and using Gent irrigations every day. But she was still wet day and night of urine and stool. And finally, her mother said, you're not going to get your driver's license until you get dry and you're wearing underwear. And so she had a new motivation. So she was sent over by her pediatric urologist, who was sort of equally disgusted with her because she had this long track record of noncompliance. And what you see here is that she has a fairly poorly compliant bladder, and she does leak all along here through her urethra. She had not been using her Mitrofanoff, so it had stenosed off. So I wasn't exactly sure. I mean, she's having sort of these phasic detrusor overactivity. She had tried Botox before, but not recently. But I thought it was unlikely that very much was going to be able to be done short of surgery. I did evaluate her urethra, and she had a recessed urethra from all of her indwelling catheters during all of her hospitalizations. So it was short, and it was a little bit stenotic, and it was really stovepipe intrinsic sphincter deficiency. So we tried some Botox, mainly because the parent, the mom, and the patient had been told many times in the past that she could never get her bladder neck closed off. It would be too dangerous for her, and so she was very resistant to the thought of bladder neck closure, and I did not think that there was any bladder neck procedure that would allow salvage of continence. That, of course, didn't change anything. So she underwent bladder neck closure and revision augmentation with tubularization of her augmentation. And this is her on post-op night 0 with the local heroes from my town. This is our local NBA team who just won the championship, and our King James right here. So, secondary incontinence, it can mean anything. I sort of put bladder stones in here because they can present with secondary incontinence. They most often I see them presenting with recurrent urinary infections or hematuria. But as you've sort of heard, that's a big part of our practice, I think, for all of us. But really the ones that require surgical revision are patients that have decreased abdominal leg point pressures, and that is mostly in the setting of artificial urinary sphincter failures or weight gain with failure of their Mitrofanov stoma as well. Overflow can be a problem with compliance. It's pretty easy to rule out with urodynamics, and I do use urodynamics in this setting to ascertain what the abdominal leak point pressure is and where they're leaking and why. I'm just going to make a nod to the role of deflux or collagen or all the rest of that stuff. I know a lot of people talk about it. I've tried it unsuccessfully in most cases. At best, I found that it temporizes the situation. This is a young lady's Mitrofanov that I injected. There were actually a bunch of these along the length of this that were popped as we took it out. When it's injected in the bladder neck, it often dissects through the bladder neck and can make a bladder neck closure very, very difficult because it sort of shreds the tissue. So I actually try not to offer this really unless I'm forced to do so. This is a gentleman who is status post appendicovesicostomy with a augmentation cystoplasty as a child. He had persistent incontinence. After that, had some periurethral injections, and then ultimately underwent an artificial urinary sphincter, which was pretty much the pattern that was done in my region for these young people. He never capped his appendicovesicostomy, and he ultimately did start self-catheterizing for continence and had a brief period of continence when he was 20. But then he subsequently developed an erosion and an infection of the devices. And you can see here this large phlegmon around the device, and it was tracking all the way down into his scrotum. He was admitted very sick and had that removed last summer. And then he was referred over to me. So at that point, he was wet all the time. He was fecally incontinent and had never gained a fecal continence. He was having erections with PD5 inhibitors and had weak ejaculate. And so we sort of ran down the list what the options were. One is bladder neck reconstruction, which is really, really challenging in adults with myelo, with their narrow pelvis, and especially those that are obese. And in his scenario, with that phlegmon all around his bladder, I assumed it would be very hard. It was his bladder neck closure ultimately was very difficult from all that scarring. Reimplant the AUS. I don't think these are very good sustainable long-term solutions for the patients, but they can be great solutions to buy some patients time until they're ready to accept another option. And that's usually how I present it. Bladder neck closure and revision of appendicovesicostomy was the third option, and ultimately what he chose. But the main issue is how to manage his bladder neck or his continence. He clearly had a really, really bad urethra, an open bladder neck. And so the options are to either close it from above with all that phlegmon and inflammation, or to close it from below and just close the urethra off from below. But in a young man, who has erections and can ejaculate, and also articulated a desire to have children, I think it's ill-advised to close off the urethra if they still have an opportunity to have erections and some aspect of fertility, even if it's with IUI. He also was fecally incontinent, so I talked with him about an ACE, or retrograde enemas, and he had a new motivation actually to be dry after our conversations, and so he underwent an ACE and a bladder neck closure revision of Mitrofanoff, and I'm happy to say actually, I saw him, he was recently at his brother's wedding, and he said, the first time he ever wore regular underwear was when he went away to his brother's wedding. So it felt good after everything I put him through, because it wasn't an easy recovery for him. So just to summarize, periadolescence is a time where patients are becoming more sexually aware and mature, and so new problems can be encountered. Existing problems related to continence or cosmesis can be amplified, and it's really a challenging psycho-emotional environment. I always start, even though I know I'm supposed to be talking about surgery, I always start with understanding the patient's goals and concerns. And for those who have never attained continence, I feel like there really is a closing window of opportunity to get them dry until they go into adult life, because most of those patients, once they get to adult life, if they're not dry, don't seem to be that concerned about ever getting dry. Counseling and education are obviously critical about what's realistic. And I have a very low threshold to use urethroplasty with or without cysto for any urethral concerns. I liberally use urodynamics, which I perform myself for all patients with pouches and incontinence, or bladder augmentation cystoplasty and incontinence, to make sure I understand why they're leaking, and I offer fertility evaluation and counseling for all young individuals who come to my clinic. Thank you.
So thank you. Just to close the session, I'd like to thank BAUS for supporting the session and allowing us just a little more time. Thank you to all of our speakers for their wonderful presentations, and thank you for listening. Thank you.